welcome back, everyone. Our next set of abstracts focuses on a very popular topic at this meeting, which is why you see a lot of it this year, and that's trauma. We all take care of trauma patients, and we all need tips and tricks, and it's my pleasure to introduce your moderators for this trauma session. Dr. Shannon Castle is the Trauma Medical Director at Valley Children's Hospital in Madera, California. Dr. Michael Dingledine is the Trauma Director at Rainbow Babies and Children's Hospital in Cleveland, Ohio. And Dr. Kim Wellenstein is our CHAP monitor and is the Assistant Professor of Surgery and Trauma Medical Director at SUNY Upstate Medical University in Syracuse. Welcome to our moderators and our speakers.
Thank you all for coming. First up, we have Dr. Brielle Ochoa presenting postoperative wound infection after primary closure in pediatric dog bite injuries, analysis of a postoperative antibiotic protocol.
Thank you for the opportunity to present our work. Dog bite injuries continue to be a common problem in the United States despite public health measures. Dog bite injuries for children in particular are still one of the most common reasons within the top 10 non-fatal reasons for ED visits in the United States for the 1 to 4, 5 to 9, and 10 to 14-year-old age groups. Dog bites are unique in that there's multiple physicians who take care of these patients, including emergency medicine physicians, pediatric trauma surgeons, and other subspecialty physicians as well. Despite all of this, there's no formal guidelines for the optimal antibiotic duration after closure of dog bite wounds. At our institution, our pediatric trauma team developed a multidisciplinary protocol for wound closure after dog bites, and this was a maximum of 3 days of antibiotics. And we implemented this in January 2021 and had input from our infectious disease colleagues as well as other specialties who take care of these children. We sought to evaluate protocol compliance and also to evaluate the incidence of wound infection and return to the emergency department and operating room after closure of these wounds. We performed a single institution retrospective review of all patients who had dog bite injuries from the beginning of 2018 through the middle of 2022. Patients were 18 years of age and younger, and they presented to the ED within 24 hours of their dog bite wound injury. We did exclude patients who had their wound closure performed at an outside hospital, whose wounds were not closed, and who had serious injury that required ICU level care or already anticipated to require multiple procedures, even if not requiring ICU level care. We collected demographic and clinical information for these patients. We defined wound infection as information in the chart pertaining to purulent drainage, fever, or worsening erythema that was related to the dog bite wound. And we defined protocol compliance as 3 or fewer days of antibiotics, which did include both intravenous and oral antibiotics. Overall, in our cohort, we ended up including 455 patients for analysis. Slightly over half of this cohort was male at 59%. The median age was 5 years. The majority of the primary dog bite injuries were to the face, followed by the extremity. Just over half of the dog bite wound injuries at our institution were closed by plastic surgeons, followed by our emergency medicine colleagues, and then our own pediatric trauma surgery team. There were also other subspecialists who repaired them in smaller numbers. For overall in this cohort, the mean number of days of antibiotics was 5.7 days. The left-sided axis here in the black line represents the mean number of days of antibiotics for each year in the study. As you can see, it declined over the study period from about 7.5 days at the start down to 4.5 days by the end of the study period. On the right side, as represented by the blue bars, was the percent protocol compliance. And so after we implemented this protocol, our compliance increased from around 29% up to 59%, so close to 60, and then had leveled off after that. To evaluate the incidence of wound infection and return to the emergency department and operating room, we did look at a subset of patients, 235 of whom had follow-up information in their chart, whether this was their primary care physician, an intentional wound check in the emergency department, or a follow-up clinic visit with our team or with another surgical subspecialty. We found that between the protocol compliant and non-compliant groups as defined at the 3 days, that there was no difference in wound infection or unplanned return to the emergency department or operating room. In conclusion, it was feasible for our pediatric trauma team to implement this protocol to limit antibiotic use and to promote antibiotic stewardship for this common injury. We were able to decrease antibiotic duration without increasing wound infections. And overall, our pediatric trauma team was able to champion this protocol across multiple disciplines, despite the fact that we only repaired 12% of these dog bite wounds. We're looking to have continued improvement in compliance in our implementation methods and to analyze the individual specialties to see where we can improve in order to continue to decrease the amount of antibiotics that are used, and also to try to troubleshoot and see why certain physicians are still prescribing more than 3 days of antibiotics. I'd like to thank my mentors and their team who worked on this project. Thank you for listening. I'm happy to take any questions.
I have a question. I've had a hard time sometimes, even when you make a formal guideline, getting people to adopt it. How can you tell me kind of the nuts and bolts of how you rolled this out in your trauma and with all the other services?
I think a big part of the success of getting this implemented was that it wasn't just the pediatric trauma team saying like, hey, we're going to do this, and this is why we think we should do it. But there were members of all the different specialties, so infectious disease, emergency medicine, plastic surgery, urology, neurosurgery, orthopedic surgery, and everyone was basically on board with this. And the recommendations were supported by the infectious disease physicians. And so I think that was a big part of getting everyone else on board. And there is actually some good literature that supports less days of antibiotics if you have a thorough washout and good wound debridement.
That's great. Thank you so much.
Our next presentation is by Dr. Laura Burkbauer from UNC. Neighborhood child opportunity is associated with hospital length of stay following pediatric burn injury.
Hi, my name is Laura Burkbauer, and I'd like to thank APSA for the opportunity to present our work today. We have no disclosures. Burn injuries are a significant source of pediatric morbidity and mortality, accounting for over 100,000 emergency room visits and 300 deaths per year in the United States. Socioeconomic and environmental risk factors, including race, parental educational attainment, and housing conditions, are associated with increased risk of pediatric burn injury. While these individual level factors are notable, the neighborhood context often reinforces individual level disparities and significantly impacts healthcare outcomes, thus helping to identify possible opportunities for intervention. The Child Opportunity Index, or COI, is a publicly available neighborhood-level index which can be used to examine the composite effects of these social and economic determinants of health. It was initially developed in 2014 with 19 domains representing factors important for healthy childhood development, and then revised in 2020 to encompass a broader array of factors, now incorporating 29 indicators across the 3 major domains of education, health and environment, and social and economic factors. The indicators have individual varying weights based on how strongly they predict health outcomes and economic outcomes. Zip codes are then categorized into quintiles: very low, low, moderate, high, and very high COI. The map here demonstrates the distribution of COI across the state of North Carolina, where the majority of patients in our study reside. Recent studies have examined COI in the context of ambulatory care and intensive care, but few studies have looked at it in the setting of pediatric trauma. So our objective was to evaluate the relationship between child opportunity as measured by the COI and the incidence and outcome of burn injuries in children. We hypothesized that children from lower COI neighborhoods would have increased burn severity and hospital length of stay. We performed a single institution retrospective review of pediatric burn admissions between 2015 and 2019. Patients were stratified into national COI quintiles based on the United States residential zip codes. Bivariate analysis was performed to evaluate differences among groups, and we performed a multivariate Poisson regression analysis to determine the association between COI and hospital length of stay. We identified 2,095 pediatric burn admissions during the study period, of which approximately 35% were Black and 14% Hispanic. The majority of patients were publicly insured and came from very low or low COI neighborhoods. Age and sex did not vary significantly between neighborhood opportunity levels, but the proportion of Black patients was significantly higher in neighborhoods with very low COI compared to neighborhoods with higher levels of opportunity. Patients from low or very low COI neighborhoods were also noted to have significantly higher burn total body surface area and significantly longer length of stay than patients in other neighborhood groups. On multivariate Poisson regression analysis, living in neighborhoods with higher levels of opportunity was associated with decreased hospital length of stay, with incremental decreases for each increase in COI level compared to very low COI neighborhoods. Caucasian race and self-pay status compared to private insurance were also associated with decreased length of stay. In contrast, Medicaid insurance and larger body surface area of burn were associated with increased hospital length of stay. Overall, we found that the majority of children with burn injuries lived in neighborhoods with low or very low COI. We also found an incremental decrease in hospital length of stay as COI increased, with children living in very high COI neighborhoods having approximately half the length of stay of those in very low COI neighborhoods. Our findings corroborate other studies demonstrating an association between COI and healthcare utilization, with children from low and very low COI neighborhoods having increased risk of hospital readmission and longer hospital length of stay for other traumatic injuries. Finally, our study points to the interconnectedness between individual and neighborhood level social determinants of health. Black children and those with public health insurance were overrepresented in the very low COI neighborhoods, but even after controlling for COI, these factors were independently associated with increased length of stay for pediatric burn injuries. Our study was not without limitations. Our data came from a single institution study of hospital admissions for pediatric burns, and though the data was collected prospectively, the study was a retrospective review. Finally, the COI 2.0 is a multidimensional composite score based on 29 factors, so we're unable to determine the specific neighborhood factors which might contribute to hospital length of stay. In conclusion, children from neighborhoods with low COI had significantly higher incidence of burn injuries resulting in hospital admission and longer hospital length of stay. Neighborhood-level public health interventions focused on drivers of childhood development may decrease the incidence and morbidity of pediatric burn injury. Thank you to the APSA organizers and to my mentors at the University of North Carolina, especially Dr. Akinkwatu.
Thank you. I have one question. So how do you take this information and move it into a practical realm of targeted intervention for those neighborhoods?
Sure. So as I mentioned, there's 29 factors, so we could not identify specific ones from this metric, but a couple of the factors that the COI encompasses include like parental educational attainment, and so interventions that are targeted at parental health literacy are one approach. Housing conditions are also incorporated, so things making sure that housing standards are sort of up to par with regulations for water temperature regulation in the area are important interventions as well.
Hi, Jeremy Johnson, Oklahoma City. Congrats on a great paper. Were you able to look at the discharge to inpatient or outpatient rehab in this population and see if there are any differences with those groups?
That was not something we looked at this time, but that's a great idea for something looking forward.
Thank you very much.
Thank you.
Next up, we have Dr. Gwyneth Sullivan from Lurie Children's Hospital presenting Pediatric Firearm Incidence and Mortality Differs by Level of Childhood Opportunity.
Great, thank you. These are our funding and disclosures. As we've heard a lot about at this meeting already, firearms are now the leading cause of death in children and adolescents. We know that neighborhood-level social determinants of health impact access to care and clinical outcomes among children, especially following traumatic injury. However, there's a gap in that we have not fully assessed child-specific factors and their roles specifically in impacting outcomes. The objective of this study was to determine the relationship between Childhood Opportunity Index and pediatric firearm injury. To do so, we first defined the distribution of Childhood Opportunity Index across the state of California. We then evaluate the incidence of pediatric firearm injury and compare patient-level secondary outcomes by a level of Childhood Opportunity Index. This study uses data from the state of California. California is one of the largest states in the United States and has a very diverse demographic and geographic distribution. This study uses data from patient discharges, both inpatient and the emergency department across the state, including trauma and non-trauma centers. We paired this with the Childhood Opportunity Index, which we heard about in the last presentation. It includes 29 different indicators across these 3 domains and is meant to measure a child's lived experience. We included all children in the state of California who presented to an acute care hospital following firearm injury between the years of 2015 and 2018. The primary exposure was level of childhood opportunity index. This ranges from very low, overall the worst, up to very high, which would be considered the best. Our primary outcome in this study was incidence of pediatric firearm injury hospital encounters, and we evaluated this at the zip code level across the state. We performed spatial analyses and identified hot spots of pediatric firearm injury, and then we also compared incident rate ratios of firearm injury by level of childhood opportunity index. Our secondary outcomes were all at the patient level. These included intent, mortality, admission, disposition, and length of stay. So first, looking at the distribution of childhood opportunity index across the state of California. You can see here the darkest blue is very low childhood opportunity, whereas the yellow is very high. We can compare this to the hotspots of firearm injury that were identified across the state. You'll see that the areas that align with the red on the right side of the screen are also areas that are the dark blue or lighter blue on the left side of the screen of low or very low childhood opportunity. Looking more closely at the metropolitan areas, you'll see this pattern persist where the red aligns very closely with blue, indicating that these are occurring more often in areas of very low or low childhood opportunity. This next graph shows the incident rate ratio of firearm injury by level of childhood opportunity. And what you'll note is that as childhood opportunity decreases, firearm injury increases. We see this for the composite index, and then also across the different domains of childhood opportunity, with the differences being most pronounced in the education domain and the least pronounced in health and environment. Now moving into the patient level analysis, this included nearly 2,600 encounters of pediatric firearm injury. We found that most children were from zip codes of very low or low childhood opportunity index. Looking at our different outcomes, first, by intent, we see that assault occurs at a higher rate in very low and then decreases through very high childhood opportunity index. However, self-inflicted injury rises from very low to very high childhood opportunity index at nearly 12% among the very high COI levels. Next, looking at mortality, mortality was highest among very high childhood opportunity index. And we know that self-inflicted injury has the highest rate of mortality overall, so we imagine that this is specifically driving that higher mortality and very high COI. So in summary, we found that the incidence of pediatric firearm injury increased as level of childhood opportunity decreased, that assaults were highest in very low childhood opportunity index zip codes, and that self-inflicted injury and mortality were highest in very high childhood opportunity index zip codes. This study is limited in that it only includes children who presented to a hospital following injury and did not include any mortality in the field. We also were limited by the fact that we only had patient home zip codes. For these types of studies, generally it's better to have higher granularity than that, even down to the census tract or census block level. And then also, we didn't know the location of injury, which would have added more information. So in conclusion, we think this study lends support to studying these trends across state levels to really see where patterns of injury are occurring and using tools such as the Childhood Opportunity Index to help identify specific at-risk populations and potential targets for future interventions. I'd like to thank our whole team, and I'll gladly take any questions.
So that was really excellent work, and I think you kind of spoke to this when you were talking about your limitations. I'm very vested in that because that whole red stripe down there is my catchment area. But looking at it, and I know there's other people in this room who know this, there's a real difference between that child who's in the low opportunity index in the middle of Oakland versus someone who's out in the farmland in Modesto or in Kern County. And so how do you propose kind of trying to get the granularity so that you can tailor the intervention to the actual environment rather than just this is bad, but in a different kind of low opportunity?
Yeah, no, absolutely, and it's a great point. I think that looking at these factors really at individual centers and hospitals is an important thing to consider as well. Studying across the entire state, we can do things like look at these hotspots where there is relatively higher incidence, but you're right, we don't know what's actually happening in individual communities without going into those communities as well and really assessing what some factors are and where the need is. So I think studies like this are just the start to identifying specific areas of focus, but more information is needed in those communities to make sure that interventions are appropriately tailored.
Thank you so much. Any more questions? Looks like someone was getting up. No? Okay. Thank you.
All right. Thank you. Our next talk is by Dr. Samara Lewis from the University of Oklahoma. Retrospective review of angioembolization in high-grade blunt traumatic liver injuries in adolescent-age children.
Perfect. Okay. My name is Samara Lewis, and thank you for giving me the opportunity to present our research on the retrospective review of angioembolization in high-grade blunt traumatic liver injuries in adolescent-age children. As everyone in the room knows, we have strong algorithms for the management of blunt solid organ injuries and trauma. And specifically, when you look at the adult algorithms for liver trauma, it's based on the hemodynamics when they arrive. And even in a patient that is hemodynamically stable, they consider angioembolization if you have any evidence of an arterial injury. This is in stark contrast to what our current recommendations for our pediatric patients are, where even if a patient is unstable, you're going to want to consider further resuscitation far before you consider any kind of angioembolization. Now let's talk a little bit about adolescent trauma. So this is a special class of your pediatric patient. They have pediatric physiology, but they have a wide range of size from childlike to adult. But their adult mechanism is actually more similar to the adults than it is for pediatrics with higher ISS scores. Now those guidelines that I previously showed you on the last slide for pediatrics are actually for children 15 years old and less. And that's all designed with the pediatric physiology in mind, where they are able to tolerate more significant blood loss without requiring intervention. Now the adult guidelines, those are actually recommended for your adults 18 years and older. So this leaves our children that are 16 to 17 years old with no current blunt solid organ injury guidelines. And then the last thing we always need to consider with these adolescent patients is greater than 50% of these children are going to be treated at an adult trauma center. So the goal of our study was to identify if the outcomes differ between adolescents with these high-grade liver injuries being treated with more pediatric-style non-operative management versus adult early angioembolization, if there was a difference. To answer this question, we used the TQIP data from 2017 to 2019. We focused on our adolescent patients from 12 to 17 years old, and we only focused on high-grade liver injuries, so this is an OSI of 4 or greater. We divided them into initial management groups, so this is the treatment they received within 4 hours of arriving to the hospital, and that was either angioembolization, non-operative management, or if they had surgical intervention. We further subdivided them by stable versus unstable, and we defined this with our SIPA and our shock index for our 17-year-olds. The outcomes that we focused on were mortality, hospital length of stay, and ICU length of stay. In total, we had 783 patients, and of that, 76 underwent operative intervention, 48 had angioembolization, and 603 underwent non-operative management. When you compare these 3 groups side by side, there was obviously a significant difference, with the majority of the difference occurring in those children that required operative intervention for their liver, with higher rates of ISS scores in that group, higher rates of mortality in that group, higher rates of blood transfusion, and they both had increased hospital length of stay and ICU length of stay. When we then divided out and looked at our angioembolization children and our non-operative management children, we found that these differences decreased and they are more similar in comparison. And when you look, the hospital length of stay and ICU length of stay was actually the most pronounced difference, with increased hospital length of stay and ICU length of stay in those children that actually received angioembolization. The other thing that we noted was the blood transfusion. There was higher rates of blood transfusion in children that underwent angioembolization versus those that were managed with non-op. We then performed a propensity matched analysis in a 3-to-1 ratio using the non-operative management children as our control and matching them with the cases in the angioembolization group to see if these differences were still going to exist. We matched on age of the child, the hemodynamic status, the ISS group, and the trauma center where they were treated at. And when we compared these, we found that there was actually no difference in mortality for these children. We did find that there was a continued difference in the hospital length of stay, with children who were treated with angioembolization having an increased hospital length of stay as those that were non-operatively managed. So in conclusion, adolescents with a high-grade blunt liver injury have similar mortality when they're managed with either early angioembolization or non-operative management, and those same children, when they're treated with angioembolization, have an increased hospital length of stay as compared to non-operative management. Thank you, and I'll take any questions.
Dr. Notrika?
Dave Notrika, Phoenix. So congratulations on nice work in identifying that there really is a gap where we don't really know what to do for these kids that are older than 15 and less than 18. So based on your conclusions, do you think that we can apply the pediatric guidelines to this subset?
Yes, I do. I mean, it's hard to prove causation because this is all retrospective, and we don't know what actual decisions were made for intervention versus non-intervention, but because the mortality rates were so low before in both groups, I think that provides you enough evidence to be able to move forward with a prospective trial safely.
I have a question. Do you think that perhaps, and this may just be conjecture, but the ICU lengths of stay were longer because they were in adult centers who were treating them with adult protocols, not because the hemodynamics seemed the same, correct?
Yes, it's hard to say for sure, but my suspicion is because there's no clear guidelines that when we do angioembolize these kids, people are not quite sure when can we move them out of the ICU, when can we send them home, when will they have a rebleed if they're going to have a rebleed. So that's my suspicion for why they have increased stay.
So how do you convince the adult trauma surgeons not to do it?
I think you have to show them the evidence. Either our guidelines for pediatric need to move up or we need to include them in the adult analysis. So the kids are not these specific kids are not represented in the data for either the adult or the pediatric, so we don't actually know. So.
Great. Thank you.
Now we have Dr. Samantha Koenig from Children's Hospital in Alabama presenting pediatric burn injuries and mortality, risk factors at play.
Thank you for the opportunity to present our work today. I have no financial disclosures. Burn injuries in the pediatric population remain a common clinical problem encountered by pediatric surgeons in all locations and practice types. Burns continue to be in the top 10 leading causes of unintentional injury deaths in patients aged 1 to 14 years old, and there remains a paucity of literature regarding risk factors for mortality in pediatric burn injuries, specifically in regard to accidental versus non-accidental burns. Prior literature establishes that there is a significant variation in incidence and etiology of pediatric burn injuries with age and a changing risk profile across different developmental stages. Prior studies have found increasing risk of burn injury among non-white populations and those in the lowest income quartiles. The objective of this study was to evaluate a nationally representative trauma database for the characterization of a pediatric burn population. We aimed to assess the utility of this database for the characterization of the demographics, burn injury characteristics, and risk factors for mortality of pediatric burn injuries. We conducted a retrospective cohort study utilizing the Trauma Quality Improvement Program participant use file from 2017 to 2019 to evaluate pediatric burn injuries. All pediatric patients less than or equal to 14 years of age with primary burn injuries were included. This was able to be done as up until the 2021 admission year, TQIP still included isolated burn patients within their database. Ages were broken down into categories as you see here, and as a caveat, children less than 1 year of age were not captured as part of the TQIP database. Patients with additional trauma codes were excluded to keep our population with isolated burn injuries. Determination of accidental versus non-accidental burn were determined by a combination of physical abuse variables as listed here. The etiology of the burn was categorized as contact or flame, and in this particular database, total body surface area and depth of burn are not available variables. As a measure of burn severity, we utilized a variable that categorized the burns into area involved, single versus multiple body regions. This table represents our patient demographics for the entire population. Males comprised 59% of the patients, a majority of children identified as white, and the highest percentage of pediatric burn patients in this cohort were from the 1 to less than 2 years of age group, with a subsequent decline in percentage as the group increased in age. When race was distributed by burn intent, we found there were more Black patients in the suspected non-accidental burn group compared to accidental. In regards to age when broken down by burn intent, the proportion of patients with suspected abuse was higher in the 1 to less than 2-year-old age group. Accidental burns were more prevalent in the 5 to less than or equal to 14-year-old age group compared to non-accidental burns. In this cohort, most patients sustained burns over a single body region compared to multiple body regions. The vast majority of burns in this cohort were contact burns, and contact burns were more often associated with non-accidental burns when compared to flame burns. Overall mortality was less than 1%. However, the mortality rate was statistically different between accidental and non-accidental burns. A multivariable logistic regression analysis performed demonstrated burns to multiple body regions carried the most significant independent risk for mortality. In addition, after adjustment for covariates, all older age groups had an independent risk for mortality compared to the youngest patients. The highest risk was represented in the 5 to less than 10-year-old age group. Black children had a higher mortality rate of 2.6 times that of white children. A non-accidental cause of burn carried a mortality rate twice that of accidental burn. Our study has several important limitations that we recognize. The TQIP database does not contain specific data that is critical to effectively evaluate burn-specific outcomes, including depth of burn injuries, presence of inhalational injury, or inclusion of the youngest pediatric patients. Further, as of the 2021 admission year, TQIP stopped including isolated burn patients, so ongoing study of the data is limited. Despite these limitations, we are able to conclude that risk factors for mortality in this pediatric burn population from a national trauma database include multiple affected body regions, older age groups, Black race, and non-accidental burns. This study is noteworthy in the identification of the highest mortality risk in the 5 to less than 10-year-old age group, but also all older children compared to younger children suffering from burn injuries in contrast to previous studies. Future studies with more detailed burn characteristics will be needed to further characterize contemporary risks for pediatric burn mortality, risks for non-accidental burns, and how social determinants may affect mortality in these populations. I'd like to thank everyone for their attention, and I'm happy to take any questions at this time.
I understand it may be kind of outside of the limitations imposed by TQIP, but did you try to do any initial analyses to try to figure out why the Black children had higher mortality, such as, or did you look at the other complications that were coded within the database, or look to see if those had higher surface area burns?
Because we don't have this body surface area burn, we just have the multiple versus single, that made that difficult. Because multiple had the higher risk for mortality, that probably played a role.
Along the same lines, why do you think the abuse burns had a higher mortality?
That, again, difficult to say,
Yeah.
Potentially because of depth of burn, but because we don't have that variable, it's tough to say. And we only have contact versus flame and then an other category, so difficult to say what those true etiologies were.
And I actually don't know because we were not a burn center, but is there a national burn database that would give you some of those kind of granular data?
There is, and that is part of the next phase of our looking into this. The American Burn Association database was what we're looking into next.
Okay, perfect.
Right. Thank you.
Thank you.
All right. Our next speaker is Pyrakea Jadhav, application of machine learning algorithm and prediction of abusive head trauma in children.
Hello, everyone. I'm a third year at UC San Diego. Thank you for the opportunity to present. So abusive head trauma usually involves shaking, blunt impact, or a combination of both in infants and young children, which leads to neurological injury. Almost 20% of infants diagnosed with AHT end up dying, and almost 20% of them had seen a physician before. So why is AHT so difficult to diagnose? Firstly, the clinical presentation tends to be nonspecific. Infants present with lethargy and fussiness, but often no external indications of trauma. The history, in addition, tends to be vague and misleading, and caregivers provide a changing story. And lastly, imaging is the hallmark of diagnosis. However, this usually results or is only a consequence of a suspicion of abuse already being present. So we hypothesized that we could use a machine learning algorithm to detect the presence of AHT based on the presenting clinical history. For subject selection, for our controls, there were 8,334 patients admitted to Children's Emergency that were trauma activated. 1,804 of those patients had only significant head and neck injury, and there were 587 patients that had full-length usable text notes. For cases, there were 504 patients admitted to the Children's Hospital that were diagnosed cases of child abuse. 303 of those patients were diagnosed with abusive head trauma, and 193 of those had full-length usable text notes. For data, demographic information collected included age, gender, insurance, race, and ethnicity. The note was the first full physician note from the encounter in which the patient was either admitted to the trauma service or diagnosed with abusive head trauma. And outcomes included, firstly, the demographic comparison between the two populations, algorithm AUC values, and the factors most relevant to the algorithm's classification ability. For algorithm design, the cohort data was split into a 70-30 training testa dataset. The top 1,000 most common words from the training dataset underwent ridge regression. The top 200 words were converted to TF-IDF vectors to allow them to be weighted based on their individual feature contribution. And those vectors plus clinical variables were fed into an XGBoost regression to output the final algorithm. So here you can see the demographic comparisons. So AHT patients were significantly younger than non-AHT patients. AHT patients identified significantly less as having private and government insurance. AHT patients identified significantly less as African American and other. And there was no difference regarding ethnicity between the two populations. Here you can see the AUC value of our final algorithm. So with race as a contributing factor, the AUC was 0.9208, and without race, it was 0.918, rounded up to 0.92. Any AUC value above 0.90 is generally considered excellent, so both iterations of the algorithm were highly accurate. Here you can see the relative feature importance that contributed to the algorithm. So age was the most important contributing factor in addition to words in the note itself, such as head injury, survey, LOC, etc. Also notably, the presence of private insurance was important for the algorithm's classification ability. And lastly, here you can see the top 15 overrepresented words by group, as displayed above. The top 5 for abusive or subdural survey C, et cetera, and you can see the non-abusive as well below. So this was the first study to use machine learning to detect abusive head trauma exclusively based on clinician notes without imaging. There have been similar studies done that use similar information to diagnose general child abuse with more notes and more imaging that have AUC values comparable to ours. So it shows good promise for this technique. The factors that we found to have the highest feature value are supported by literature. The exclusion of race and ethnicity did not hinder the model's accuracy to a significant degree. Further testing does need to be done with larger sample sizes. However, we do believe that provider documentation is crucial for earlier detection and screening of AHT. So in conclusion, we do believe that machine learning algorithms have the ability to distinguish with high accuracy the presence of AHT given clinical variables and free text notes, highlighting the importance of accurate provider documentation. Just want to say thank you to everyone on our team, my mentor, Dr. Ignacio, and APSA for the opportunity to present. Thanks.
Kathy Barsness, San Antonio. I think it's an interesting thing to use the machine learning, but you used it on the actual index when the intracranial injury was identified. Have you taken this machine learning and looked at their previous presentations to healthcare? Because we know that children with NAT have had numerous interventions or evaluations prior to the index. And so I'm just curious, have you been able to apply this to prior presentations? Again, thank you.
Yeah, that's a great question. Actually, so when we initially started this, we wanted to compare patients that had been diagnosed with AHT on their first encounter versus patients who had been diagnosed with AHT on their second or third, for example, encounter, to compare that difference. Unfortunately, the numbers were just too small to do that comparison. So instead, we decided to compare patients who were diagnosed with AHT, just that first presenting note, versus a comparable control that had the same injuries but didn't have that mechanism of non-accidental trauma. But definitely in the future, if we can have a larger database, that's something that we want to explore.
Dave Notrika, Phoenix. Are you concerned that the machine learning is already taking into account the opinions of the physician who's documenting the record already? And then I'll let you answer that, and one other follow-up question.
Yes, absolutely. Definitely one of the biggest limitations of this is, and any machine learning project, is that it can only be as accurate as the provider and the information that it's given. So definitely some of those biases can be intrinsic in the information itself. I think hopefully as there are further evolutions and more objective data that we can feed it, we can try and eliminate that. But that is definitely a concern.
And then your other group had head injury as well, right?
Yes.
And so I would actually caution that group that had head injury is not the best comparison group, because those patients are suffering from supervisory neglect. So if they had been appropriately supervised, they would not have had the head injury to begin with. So I'm not 100% sure that comparing the abuse to the neglect is the best way to do the analysis.
Yeah, that's a good point. Definitely something to look into in the future.
Alex Casar from San Antonio as well. I have a question. So you are using natural language processing, machine learning. You're trying to do this as a screening, kind of like that's your ultimate goal?
Yes.
Did you consider using just the first part of the note before the analysis and plan as the data set?
Yes.
Okay, sorry.
So this analysis was done with only that first initial presenting note before any diagnosis of abuse was given.
Just because the words that are proving as your highest sort of elements of significance are survey and subdural, which kind of sounds like maybe the emergency physician wrote like, we did a CT scan because we were concerned they had a subdural hemorrhage, so that kind of brings you into the list of like, oh, ophthoconsult, retinal hemorrhage, like all that stuff. And they're probably concerned and they ordered a skeletal survey, or like, we'll follow up skeletal survey. And that's why survey is kind of popping up. So I was just wondering if there's other words more related to the mechanism or something else that they wrote in the sociocultural aspect of the note that would actually be more predictive as a screening tool.
No, definitely. And I think when I was looking into the words that were most important on that feature contribution graph and in the context they were used, a lot of the time it was usually because a physician was ordering those rather than that having already been ordered. But that's definitely a good point. If we can kind of eliminate all of that altogether and just have it be the presenting information, that would definitely be the most ideal iteration of something like this.
Thank you.
Thank you.
Next, we have Catherine Liu, a medical student at the University of Rochester School of Medicine, presenting In Search of Truth, Modeling Activation Level in Pediatric Trauma.
Thank you to APSA for the opportunity to present our work.
Scoot up toward the mic.
Oh. So we have no conflicts of interest related to the study, but our work was supported by a KL2 award, and I previously interned at Medtronic. So why are we trying to model trauma team activation? Really, at its core, trauma team activation is a classification problem where we take labeled data to teach the model and then have the model try to predict unlabeled cases. For example, on the graph to your right, red dots represent patients who require a full activation, while blue dots represent patients who require a partial activation. Our model is trying to find the most optimal way to separate these two groups of patients. In order for our model to be effective, though, we need an appropriate and accurate ground truth to capture activation level. Ground truth is what the model is trying to predict, which directly impacts model performance. But it's extremely difficult to determine how injured a patient is based on the limited set of data available at the time of triage. The best way that we currently know how to predict activation level is by using retrospective metrics, such as the NFTI criteria as well as the Cribari matrix. As we know, neither of these metrics are perfect, and there currently is no gold standard, but these are the tools that we have available for evaluating under and over triage. The purpose of our study was to curate an appropriate ground truth to accurately train a machine learning model to predict trauma activation level. And our hypothesis is that the combination of Cribari and NFTI together will yield the highest model performance and capture the greatest variation in patient characteristics. In terms of our study, we initially needed to prepare our data. We retrospectively reviewed 1,366 pediatric patients under the age of 18 years old who triggered a trauma activation at our pediatric trauma center. Then we selected features that were reasonably available at the time of triage. Lastly, the patient was given a predicted activation level based on each of the 3 ground truths that we had selected. 2 machine learning models, logistic regression and random forest, were tested 1,000 times separately in trials using the 3 different ground truths. Classification accuracy for trauma activation level was quantified using area under the curve, or AUC. Cribari, NFTI, and Cribari combined with NFTI were the ground truths that we further examined. Cribari is closely based around injury systems, while NFTI is more outcomes-based. Thus, we created a 3rd ground truth using the union of the 2 to see if a greater number of patient characteristics could be captured. In order to compare these 3 ground truths, we delved deeper into patient injuries and demographics. As we can see from this table, neither Cribari nor NFTI is perfect at capturing the different injuries across the data set. However, we found that NFTI is better at capturing penetrating injuries as well as mortality. When looking at blunt mechanisms of injuries such as motor vehicle crashes and falls, Cribari still captures fewer patients than NFTI, but Cribari captures a different set of patients, making the combined ground truth more powerful. Therefore, as a whole, the union of NFTI and Cribari makes a more solid ground truth than either one alone. Once we identified that Cribari and NFTI would be the best ground truth from a clinical standpoint, we trained machine learning models such as logistic regression and random forest. This table shows the area under the curve for trained clinicians with respect to the ground truths. Our trained trauma triage nurses were correct about 60% of the time, regardless of the ground truth used. After we trained and tested our models, we compared how each of these models performed in comparison to our trained clinicians. Comparing model performance to trained clinicians, we can see that all machine learning models outperformed trained clinicians with respect to all 3 ground truths. This indicates a high possibility for improved resource allocation as well as for patient safety. In terms of pure model performance, we can see that logistic regression with Cribari performed the best. The numbers on the table represent how well the model can mimic the Cribari, NFTI, and combined criteria respectively. Since the model is mimicking the answer that we provide it, AUC scores may not correlate directly with patient outcomes. Thus, even though Cribari has the best performance, it does not necessarily mean it is the best ground truth, because it doesn't fully capture all patients who may need available resources. Thus, despite a slight degradation of model performance, Cribari and NFTI is still a better ground truth. In conclusion, machine learning tools can be beneficial in the setting of trauma team activation level determination, and all machine learning models had increased accuracy and reduced variability compared to trained clinicians. While models performed best with Cribari alone as the ground truth, the combination of Cribari and NFTI together better captures clinically important information, thus making it a more ideal ground truth. We caution against using model performance alone to determine ground truth. Rather, clinical judgment in conjunction with model performance must drive decisions with regards to ground truth. Thank you for the opportunity to present, and I'd like to thank my mentor, Dr. Wilson, and I'm happy to take any questions.
So if you're envisioning this being better than the triage nurse, do you see a situation in which you have this machine learning model listening to the dispatcher MICN call? And if so, how would you kind of tailor that? Because to me, it sounds like some of the variables are not things that always are in what I've seen in people's trauma activation criteria. So would you change the criteria? What would you do?
So this would be very institutionally dependent, depending on what the institution already uses. But I think what we were envisioning was that we would have a tool built in, or a clinical decision support tool built into the EHR that the trained clinician can fill out as they're getting the call, and it'll make a recommendation that the trained clinician can then update based off of their clinical expertise.
We have a question here.
Hi, that was very interesting work. My name is Ben Padilla. The question that I had is, in the 20% of the time that the model was inaccurate, was it failing to activate a full activation, or was it over triaging or under triaging? Because I think that would be an important variable to know.
Yes, so we had a mix between over triage and under triage when the model was incorrect. The over triage rate was about 31%, I believe, and then the under triage rate was about 46%. So it had a combination of both within the over and under triage.
That's excellent work. Thank you very much.
Thank you.
Thank you.
Our next presentation is by Dr. Lee from UC Davis. Pediatric trauma transfer patients have low rates of additional traumatic injuries.
Thank you for the opportunity to present. We have no disclosures. Trauma is a leading cause of disability and death among children. After a traumatic injury, pediatric patients are frequently transferred from the initial hospital to a regionalized trauma center for a higher level of care and subspecialty evaluation. Due to the concerns about the potential for missed injuries, pediatric trauma teams are often involved in the management of transferred patients regardless of patient acuity or the mechanism of injury. Traumatic activations resulting from transfers may delay evaluation and diagnostic testing of other patients seeking care in the emergency department. Systemic improvements must ensure safe and effective care for pediatric patients. A better understanding of the rate of additional injury identification among pediatric transfer patients may better guide allocation and optimization of trauma resources at both transferring and receiving centers. The purpose of the study was to determine the rate of additional injuries identified in transferred pediatric trauma patients. We hypothesized that these patients transferred for subspecialty evaluation of isolated injuries would have a low rate of additional injuries identified. We performed a retrospective cohort analysis from our institutional trauma database from January 1st to December 31st of 2019. And this included pediatric trauma patients less than 18 years old who were transferred from another hospital to the Level 1 Trauma Center with isolated injuries as diagnosed by the referring hospital. Patients who were transferred for polytrauma were excluded. The primary outcome was identification of any additional injuries on trauma workup. Secondary outcomes included the need for operation, total hospital length of stay, and mortality. There were 530 patients that met our inclusion criteria. The patient characteristics were similar between the types of isolated injuries. Focusing on the three most populous groups, patients with the isolated orthopedic and plastic surgical injuries were less severely injured than patients with isolated neurosurgical injuries, as evidenced by the injury severity score and the proportion of patients with the Glasgow-Coma scale of less than 15. Orthopedic patients also more often required surgical intervention. The most common injuries identified prior to transfer were isolated orthopedic injuries, followed by the isolated neurosurgical injuries and plastic surgical injuries, and this is listed in the order on the table in the first two columns. The overall rate of additional injuries identified was 2.6%. Patients transferred with neurosurgical injuries had the highest rate of additional injuries at 6.7%, which was followed by patients with isolated plastic surgical injuries. Only 1%, or 3 patients with isolated orthopedic injuries, had additional injuries identified, and this included a wrist fracture, a T4 compression fracture, and abusive trauma. As isolated orthopedic injury was the most common, these patients were compared to the remaining patients. Again, there were no differences in the sex or race, the proportion of patients admitted, the total hospital length of stay, or mortality. However, patients with isolated orthopedic injuries were less injured with lower injury severity score, and again, with a proportion of GCS of less than 15. Importantly, when compared to the non-orthopedic transfer patients, isolated orthopedic transfer patients were significantly less likely to have an additional injury identified, and this persisted on the multivariate regression model. No other patient factors were significant predictors of additional injury rates on this multivariate analysis. Transfer to trauma centers is appropriate and indicated for these orthopedic patients, especially with higher rates of operative intervention when comparing to the remaining trauma transfer cohort. However, this implies that this may be a population of interest to investigate resource-optimized means of transfer. The overall rate of additional injuries identified for pediatric trauma patients transferred for subspecialty evaluation was low at 2.6%. Patients transferred with isolated orthopedic injuries had a significantly lower rate of additional injuries identified on trauma workup, and this persisted on multivariate analysis. Future research investigating alternative means of patient assessment, such as telemedicine consultation or direct transfers to subspecialty services for evaluation, could help optimize resources while providing the excellent and timely care for this specific population. I'd like to thank my mentors for this project, and I'd be happy to take any questions. Thank you.
So, what percentage of your patients were pan-scanned before they were transferred?
That's an interesting question. Thank you for the question. Because this is our institutional database and it's an administrative database, some of the granularity and the data wasn't available, so that is something that we would have to look further into. Thank you.
Dr. Narcio.
Romy Ignacio, San Diego, well presented. I think this is one of those that's a little bit more than just looking at the isolated injuries. Can you clarify again from your study, are you trying to say that we shouldn't transfer those with isolated injuries, or maybe we shouldn't just activate those for trauma transfers?
I think it could be institutionally dependent. I think what we're trying to say is this is a specific population that can be further managed depending on the institution. One way would be to do something such as telecommunication to the specific subspecialties where they can be evaluated, especially by the orthopedic patient, the specialties, to either be transferred for full activation or for in-person evaluation, or this allows them to have an in-way for orthopedists to have outpatient services and outpatient evaluation and diagnosis and further follow-up.
I think some of the barriers, though, are not just the type of injuries. The orthopedic specialists, especially adult guys, if their physio plates are not fused, they're going to automatically transfer regardless. Two, it's the anesthesia provider that has to take care of that fracture. So there's more than those simple things that you're looking at. And of course, there's the issue about NAT, and the best place for those patients to go to is a children's hospital. Again, nice job and stuff, but I think there's a little bit more complexity that comes to that when you're transferring patients.
Thank you.
Of that 3% of additional injuries, how many of those injuries are actually clinically significant?
So the additional wrist fracture, I believe, had to have some kind of procedure to either reduce or operative intervention. The other compression fracture and the non-accidental trauma did not require any significant interventions, but needed to be identified.
Right. Great. Thank you.
Thank you.
Last but definitely not least is Dr. Stephanie Papillon, presenting from St. Christopher's Hospital in Philadelphia, presenting a novel technique to identify children at high risk for physical abuse in a nationwide trauma registry.
Good afternoon. and thank you for the opportunity to present our work. We have no disclosures. Physical abuse is a leading cause of death in children with the highest fatality rate in children under 1 year. The Trauma Quality Improvement Program database can be used to develop clinical decision tools to identify high-risk children. TQIP, however, does not include the ages for patients at the extremes, including children under 1 year. So here we describe how to capture those infants within TQIP for the purposes of studying child abuse and to develop such tools. Pediatric patients were identified within the TQIP database from 2017 to 2019. Patients were excluded if they had died in the ER or if they had a penetrating injury. To select for the infants, we used the World Health Organization growth standards for length for age and weight for age. We selected the 97.7th percentile such that a patient with both a length at 80.5 centimeters or below and a weight at or below 12 kilograms was included. And using this criteria, we identified an additional 19,916 patients. To identify children undergoing an evaluation for physical abuse, we used predefined variables within TQIP that are listed on the slide. We also used ICD-10 diagnosis codes for confirmed or suspected abuse. Using the WHO growth standards for height and weight, we were able to demonstrate good separation between patients at the extremes of age. So that is adults over the age of 89 and then children under 1 year. On this scatter plot, height in centimeters is on the x-axis and weight in kilograms is on the y-axis. The black lines are the 97.7th percentile for a child at 12 months. And below that cutoff, we can see that there's a strong association for the infants who are represented by the green dots, whereas above that cutoff, the adults, there's a more positive, distinct association seen for the adults. A total of 20,513 patients had a report of physical abuse. And this bar plot demonstrates the distribution of these patients by age that is on the x-axis. 46% of these patients were infants, and they are represented by the first bar. And you can see that as the age increases, the number of patients with a report of physical abuse progressively declines. When we compared this group of patients to those who did not have a report of physical abuse, these patients were younger, with a median age of 1 as compared to 9. They were more likely to be injured in a private residence. And we see what likely represents some implicit bias in that a higher percentage of these patients were Black and a higher percentage had Medicaid insurance. We looked at the injuries associated with having a report of physical abuse for the entire cohort. And these are the age-adjusted odds ratios, and the black line is at 1. For the most part, when we specifically select for and include the infants in the analysis, the odds ratios increased, and there were just a couple of exceptions. Burns was one of those exceptions where when we select for the infants and include them in the cohort, the odds ratio was less than 1, whereas when we look at children older than 1, burns were associated with a report of physical abuse. We also saw a reverse association for fractures of the upper extremity, where when we include the infants in the analysis, the odds ratio is 1.28, whereas when we look at children older than 1, fractures of the upper extremity were not associated with a report of physical abuse. In summary, the WHO growth standards for both weight and height can be used to identify infants within TQIP. Infants are the largest percentage of patients being evaluated for physical abuse, and therefore including these patients is important for any analysis on child abuse and can improve the accuracy of clinical decision support tools. Thank you for your time, and I can answer questions.
That's really great work. Do you think when you were doing kind of prep research for this, that prior work had included in TQIP or NTDB data sets had not included those infants, and so was kind of like false conclusions or different conclusions?
So we think we've seen both, where some studies will specifically state that they looked at children from 1 and older. There's other studies that have not been specific about the age group. We've reached out to one of those groups, but haven't yet heard back yet how they accounted for the infants under 1.
Okay. Dr. Russell?
Yeah, just a general comment for anyone that's has influence with TQIP in the audience. May be helpful for it to code those infants less than 1, because I think we can find out some more information as far as trauma goes, and it might be helpful. I don't have any influence. But.
I know there's somebody
Agreed.
here. Any more questions? Thank you so much. Okay.
Thank you. So, before the next scientific session, we actually have another history video. This is Dr. Jay Grossfeld being presented by Dr. Robert Russell.
It is indeed a privilege to give a tribute to Dr. J. L. Grossfeld, one of the most accomplished pediatric surgeons of our era. I had the pleasure of interacting with Dr. Grossfeld during my pediatric surgery fellowship training at Indiana University, and I know many of you in the audience have had the pleasure of meeting, interacting with, and getting to know Dr. Grossfeld. He was born in New York City in 1935 and attended undergraduate school at Washington Square College at New York University, where he received a BS in biology and a BA in history. He moved on to medical school at the New York University School of Medicine and then trained in general surgery at NYU and Bellevue hospitals from 1961 to 1966. After serving 2 years as captain in the U.S. Army Medical Corps and receiving an Army Commendation Medal for distinguished service, he trained under Dr. Clatworthy at Nationwide Children's Hospital at The Ohio State University. He returned to NYU in 1970 for a short 2-year stint on faculty, and then in 1972 was appointed professor and director of pediatric surgery at Indiana University, and the first surgeon-in-chief at Riley Children's Hospital. His impact there was immediate. In 1985, he was appointed chairman of the Department of Surgery at Indiana University School of Medicine, the first pediatric surgeon in the U.S. so honored. He pioneered the development of pediatric surgery in the state of Indiana and set the standard for surgical care of infants and children. Through his efforts, the Department of Surgery, the Division of Pediatric Surgery, Pediatric Surgical Oncology, and related research achieved world-class status. He developed an excellent training program and was a role model for his trainees. From an academic perspective, Dr. Grossfeld's career was extremely productive. He published 492 scientific articles in peer-reviewed journals and 135 book chapters, nearly all with students and residents. He edited 9 textbooks and was the editor-in-chief of the renowned 2-volume textbook Pediatric Surgery. He was also editor-in-chief of the Journal of Pediatric Surgery, which he led to be the leading pediatric surgery journal in the world, and was founding editor of Seminars in Pediatric Surgery, for which he served as editor-in-chief for 25 years. Throughout his career, Dr. Grossfeld accumulated a multitude of honors. He was a member of every important surgical organization in the U.S. He was chairman of the American Board of Surgery, president of the American Surgical Association, the Halsted Society, WOFAPS, the Central and Western Surgical Associations, the surgical section of the American Academy of Pediatrics, the American Pediatric Surgical Association, and first vice president of the American College of Surgeons, to list a few. He received the highest honor medals from the AAP, APSA, and the British and European Associations of Pediatric Surgery. Dr. Grossfeld was a master surgeon. His memory of his patients and the surgical literature was encyclopedic. He cared for literally thousands of children, correcting newborn bowel obstructions, removing tumors, and on, changing lives forever. He often spoke of the opportunity we had to change a child's life, giving them a lifetime. and this drove his attention to detail. Residents in general surgery and fellows in pediatric surgery had the opportunity to watch Dr. Grossfeld in action. His love for children and surgery was transparent. His demand for attention for detail was evident when he said, "It is the little things that are important." Those that trained with him wanted to do better because we could see his drive. His sayings, "Do what's right," "What this child needs is a doctor," and "You need to read about your patient," seemed simple, but they changed our lives and changed how we cared for children. All of the residents, fellows, and younger faculty are forever indebted to his mentorship and leadership. Dr. Grossfeld's greatest legacy is his family. He was happily married to his devoted wife, Margie, for 54 years, and together they set a standard for a successful and close family life. He was a devoted father and grandfather to his 5 children and 17 grandchildren. So on behalf of the thousands of patients who are alive and in better health because of his care, on behalf of all the residents, fellows, and faculty who have benefited from training under Dr. Grossfeld, and those who have had the privilege to watch and learn from his friendship and leadership, the world of pediatric surgery and the care of children are better because of him. Thank you.
So thank you again to all the excellent presenters and discussants for the well-attended trauma session. Thank you. Up next is our scientific session number 6 on global health and surgery. I'd like to introduce our moderators as they come up. We have Dr. Krista Grant, who is an associate professor at Children's Hospital at Westchester Medical Center in Valhalla, New York, and Dr. Allison Linden, who is an assistant professor of surgery at Emory University School of Medicine in Atlanta, Georgia. And moderating again our chat is Dr. Kim Wallenstein, who was here for our previous session. Thank you, guys.